Hi, everybody. So, yeah, unfortunately, I've got to do this one with you guys again, but I'm sure some of you may have watched it last year when we had initially done it, X-rays of the upper arm, and I tried to upload it to YouTube. And unfortunately, I had two teaching videos inside, but they were done by other well, content creators, and there was a copyright issue, so they didn't allow me to upload it. Luckily, they didn't remove the channel or anything like that because it's educational and there's fair use policies in it, but they just felt it was unprofessional, I suppose. So I'm just re-recording it for you guys. Nice chance just to go through shoulder dislocations and clavicle fractures and things like that. So a bit of revision, and we do have to cover shockable rhythms as well, and one or two of the other ones that couldn't get uploaded. So the next few weeks, maybe just a bit of revision as well. And thank you to all of you who have been going onto the YouTube site and looking at the videos. It's not monetized. You don't earn anything from it because it's unlisted. And I see people can subscribe to Yusuf Muhammad. So, if you get alerts, then, if you don't want to check the group and that, I don't think you can just subscribe to the particular playlist. So I didn't do that. So two of the doctors had done that, and I see they get they get their notification. So thanks, guys, and I hope the website is also helping you guys as well to navigate through all of these, and yeah, hopefully we can have some fun. So, in this one, just before we start, we had a few videos on how to do reductions and things like that. So those are not available now on YouTube, but if you follow the Google Drive link, you'll still be able to find them there. So you can watch them directly from the Google Drive, or alternatively, you can just download them and keep them. So I put quite a few videos on how to reduce shoulder dislocations and things like that. All right. So we had done X-rays of the upper arm. This was part one, and part two was meant to be more fractures of the humerus, which unfortunately also wasn't allowed to be put on to the YouTube channel. So I'll also do that in the next coming weeks. And then we'll actually have a good set of X-ray lectures all the way from the head, face, neck, all the way down to the pelvis. And then once that's all up to date, and then we'll start moving on to the femur and the knee and so on until we get right to the tips of the toes. And then we'll discuss some other things after that. Okay, so let's get into it, and let's start. So so in this one here, we're just going to have a look at an acromioclavicular dislocation. Now, in a previous one, we had actually discussed the sternoclavicular dislocation, which is quite, especially a posteriorly displaced ACJ dislocation. Acromioclavicular joint dislocation is quite a problem, but very rare, luckily. And let's just call it ACJs, all right? So an ACJ is quite easy to figure out on a patient. So as you can see, there's a separation between the clavicle and the acromial joint. So it is a separation, it is a dislocation, all right? So generally the force is applied from above the shoulder. So it's coming down from this direction. Let's see if we can just annotate that and just show you guys. So in other words, the force is traveling this way. All right. So the force is traveling that way, and that causes the shoulder to move down, and then causes the separation that we see over here. Okay, so the patient can't touch the opposite shoulder, which is the most common clinical sign, but most of us, I must be honest, we don't really check for it. And the easiest way to figure it out, what I've found, and this is just a bit of, I suppose, my own clinical experience, is that if you you yourself can feel your ACJ quite easily. I mean, I'm well over 100 kilos and I can easily feel it. My wife is complaining about my weight at the moment, but that's besides. So you can feel your ACJ quite easily. So what happens is you get a prominence of the clavicle and a lot of tenderness around this area. So if you feel that, you got to start suspecting this ACJ dislocation, and it's one that's commonly missed. And it's not anybody's fault. I've seen many doctors miss it over the years, and they often, send patients home and things like that. Because everything else looks kind of normal. There's not many fractures associated with this type of injury, and it's, basically just a widening. So they do give us the measurements here. The normal is 8 millimeters, so about the width of a standard finger. That's more or less what it should be. I mean, a good practice for everybody is to measure your fingers, because, like, I know. I've measured mine, and I know, like, my thumb, for example, is 1.5. My index finger is 1 centimeter. So it gives you a quick reference guide to actually be able to figure out how wide things are. And then so you can see the distance between the coracoid and the undersurface of the clavicle remains normal. Right? Upper of normal is 13 millimeters. So even though we won't get, you're not going to worry too much about that. You're more going to worry about this distance over here. And it is extremely painful. Management is quite easy. The patients are normally placed in a sling, unless it's quite a severe dislocation, a dissociation, and then sometimes they need for it to be, reduced. But I've never actually seen one being reduced, because I've never seen one that's that bad, luckily. So that's good. But I don't work in orthopedics, so I'm sure they've seen much worse. And some of you who have worked in orthopedics may have seen much worse. So this is something called the Rockwood classification. So it just shows you what happens. So this is your normal clavicle. This is your, your chromium and your ACJ over here. So as you can see, type 1, it's just a split. Type 2, it gets a bit further. Type 3, type 4 is where the clavicle is pushed inferiorly and there's damage to the ligaments. And you can see type 5. And of course, type 6 would be extremely severe. So in these cases, the classifications, I always tell you guys, I mean, classifications are nice to know, but it's good if you work in the department. It's always something nice to know. I don't say don't know it, but to be dead honest, it affects more the management. So once you reach stage 3 and above, it's normally operative management. It's very difficult to manage these conservatively, whereas stage 1 and stage 2 are normally managed conservatively, and these are by far the most common types. Unless and these I've noticed more commonly in polytrauma patients and things like that. Like for instance, I remember a patient a few years ago who did have a similar injury. I think it would have fallen somewhere between a type 5 and a type 6. But there was a lot of associated trauma, rib fractures, C-spines. It takes a lot of force to actually move a bone that far. So, it has to be seen in context as well. But it's nice to know. And, nice, especially if you're an intern or younger doctor. Just remember this classification, something you can pull out on your ortho ward rounds, and they'll all clap and make you feel like a big person. So this is endochromial fracture. Now, these are normally due to direct blows from above the shoulder, right? So that's what causes the fracture. So it may also occur with superior shoulder dislocations, which we'll look at just now. The patients will have localized pain over the acromion, and it's often subtle, needs CT or MRI. Axillary or scapular views can sometimes help, but to be dead honest, it is a difficult one to pick up. It's not that common to pick up as well, but it does happen. And it can occur in isolation as well, but these are not common cases. It's just something you need to know. So I'll give you the same advice that I've given you all the time. It's very easy to concentrate on big structures. And when your patient is in a significant amount of pain, there's a significant amount of tissue swelling, which we can see in this case. It's even extending down into the arm. There's a bit of swelling around here. I mean, this is not a normal, soft tissue spread that you see over here. So all of these things need to be taken into context. So if your patient comes in, mild swelling, can move the arm, I mean, of course, you're not going to take an hour looking at the X-ray, but if the patient has suspicious signs, then you really need to look through, and you may pick up one of these things. Okay, let's go to another one. So now I'm going to talk about shoulder dislocations, which are always fun. because they're so common. They are so common. Now, I must give a disclaimer. As much as I talk about shoulder reduction, it really does depend on the setting in which you work. So, for instance, I remember being a young doctor, even working in surgery, not even in orthopedics, but I would do shoulder reductions in the emergency department when I was called to see patients and things like that. And, as an intern, also, I remember doing a lot of shoulder reductions. Even as a GP, I remember doing shoulder reductions. And I remember when I first started here at Madadeni Hospital, I was quite surprised that, shoulder reductions weren't done. And I did about 3 or 4, and then I was chastised by the manager. So, must be done by orthopedics. And then, of course, the orthopedics would get angry because we were sending them shoulder dislocations because it is a bit of work. But I understand the rationale behind it. So in some hospitals, especially if there's been liability before and litigation, they may want the orthopedic surgeons to do it. So generally reductions now, like in our hospital, are done by the orthopedic doctors. And you may also work in a situation where you do most of the orthopedic work. I mean, I remember as a young doctor putting on all the POPs, doing all the reductions, doing all the tendon repairs, things like that. But I see it has become a bit different now. I'm just showing my age as well. So here we have what an anterior dislocation should look like. Okay, so an anterior dislocation, it's 90% of the dislocation. So it is the most common one. It's forced abduction. So the let's get it up here. Sorry, let me get this here. So abduction, right? So what's happening is that the hand is physically moved away, all right, and then it's internally rotated. So I'm not sure how I'm going to show that. It doesn't really have anything to show it. Externally rotated. So let's put it as a it's rotated in that direction. Okay, so what happens is that then the shoulder then pops out of the glenoid cavity, and it's better to reduce it as quickly as you can. Not always possible, but it is the best to do. So what happens is when you suspect an anterior dislocation, tell the radiographer that that's what you suspect. So what happens is they take this view where you can see the scapula and the acromion and the coracoid process, and you can see it forms a lovely Y shape, all right, with your glenoid cavity sitting more or less there. Now, if your head of your humerus is in front of that, now it's supposed to be covering at least 80%, if I remember correctly, but any movement that looks suspicious, and of course, based on clinical grounds and what you suspect as well, then, you have to consider that a subluxation at least, or an anterior dislocation. Now, what's the difference? Generally, in a dislocation, there's quite a bit more ligament and tendon injury involved, and sometimes complete transection. Whereas with subluxation, your ligaments are generally intact. Your tendons are generally intact as well. However, they've been stretched, and so you get a movement, but not a complete dislocation. So I remember one of my orthopedic masters in the years gone by used to always make us laugh whenever we used to get patients referred with incomplete dislocation. This always make us laugh because it's either dislocated or it's not. An incomplete dislocation is a subluxation. So anyway, and there's many reduction methods as well, right? So this is so it's the AP, the scapular Y, and axillary view. So you can ask for an axillary view as well, and it's quite easy to see that it has popped out. In this case, you've got a fracture as well as an avulsion fracture in this case. So that has to do more with the deltoid ligaments and things like that. Right? I think the pectoral as well in that case, but I need to revise my anatomy just to be 100% sure. So what's happening exactly? So this is what happens. Okay. So it just moves anteriorly. That's it. There's nothing else to it. Just comes up, needs to be put in. So what's the issue that we face? Now let's just go back to it. So the issue that we face now is mainly, that there's neurovascular stretch. So you've got, your brachial plexus that's running through there. You've got your radial artery. You've got your subclavian. You've got all of these that are running, and they now put under stretch. I must be honest, I have seen patients where there has been neurovascular impairment, and those need to be reduced very quickly. And generally, in the majority of patients, say about 99% of your patients, there's no neurovascular involvement, but always note it down. Just make sure that you do, note whether there's a good pulse and sensation and things like that. But the longer you leave it, the more the stretch on the neurovascular bundle, and the greater damage that can occur. So that's why it's important to reduce it as quickly as possible. So these are all the methods that you can use, and each one is valid, and each one has its own reasons for why it works and why it doesn't work, and why this doctor prefers that and why that doctor prefers this. In all honesty, the main and most important thing is to make sure that you learn a method. So that's why, like I say, you can go to those other videos and have a look, or do your own research. And it also depends on your circumstances. So you have a two-person method. Here you have, an assisted method with weight. Here you have a single-person method. So it all depends on what you're capable of doing. I used to actually stick my, I had one of my consultant, when I was in orthopedics, showed me a very lovely method of just putting your foot inside there. You just got to take off your shoes and you just pop it in like in a second, and it was very unlikely that you'd cause neurovascular. But that was just my preferred method. But there's so many methods, So the most important thing is learn how to reduce, because you may be stuck in a situation at the roadside, sometimes in a practice, sometimes in an area where you don't have orthopedic support, and you need to know how to be able to reduce them. Okay. So, like I said, there's so many methods, and the videos, if you go through them, they give you all of that information. And like I say, it's on the Google Drive part. So if you go through to our radiology section of the website, click on the Google Drive, and then just look through for those videos. I've got them better marked out so that you can actually see them. Okay. So what's happening with the posterior dislocation is that you have forced posterior movement. So it's being forced backwards and then internally rotated. So what that causes is that it just causes to pop out from the glenoid and then pop behind the glenoid as well. So it's very frequently missed, because when you look at it like this, it may just look like a subluxation. But if you actually look at the scapular Y, you can see that it's trending towards the back. Now, it is a difficult one to pick up, I must be honest. And the thing that actually helps you is this. The patient will keep their arm internally rotated. So they just keep it in that position. It's just stuck next to them, and they will not rotate it externally no matter what you do, as compared to a subluxation, which you can generally rotate and things like that. Although not much, but it's just to give you that explanation. And the axillary view, of course, gives it much better. You can see, and this is one of the good uses of an axillary view, because you can actually see the posterior dislocation over here out of the glenoid. Okay, so the most important thing is not to miss it. It isn't common, but it does happen. MVAs, fights, any force that's applied from the front of the shoulder can cause it. So let's just have a look at the light bulb sign, which is also an important thing to note. So what happens is that normally we can see the greater tuberosity of the humerus, and then when you have a posterior dislocation, there's no evidence of that. So it looks like a light bulb. In other words, it's a uniform curve that goes around. Now, I must be honest, I haven't seen the light bulb sign except in posterior dislocations, and it has to do with the rotation. So what's happening is, because you're having this internal rotation, the tuberosity is actually now in front. It's basically sitting here. Let's try put that there. So we're actually looking at your tuberosity sitting about there as compared to sitting there. So that's basically what we're talking about. Okay. All right. So that's one of the great indicators sorry. Now I'm just marking everything. Okay. So that's one of the very good indicators on X-ray, and it's one of the ones that's easily missed. Okay, then we get an inferior dislocation. Now, inferior dislocations are quite uncommon. I've only seen one in all my years, and it was quite an interesting one to see, because the patient actually did not have neurovascular injury, which was very surprising. I mean, we actually kept him for 2 hours, his pulses were fine, everything was okay. So it is the least common type of fracture that you see, but it has the highest, percentage of neurovascular damage that can occur. So the patient would present with their arm raised above the head, simply because now the humerus is forced into that upward position, and it's so painful and it's so tiring for the patient. So really you want to get it back in as quickly as possible. Now this reduction is not as easy. It does require quite a bit of traction to be able to get it in, and unfortunately the rotation of the arm can sometimes be an issue as well. And the reason for that is when it dislocates, when it moves in this position, you've got this entire neurovascular bundle that's now basically following this track. Let me see if I can just draw it for you guys over here. Just want to try and get it here. Yeah. So what we have, just change the color. So what we have is this entire neurovascular bundle that starts from there and now should be going in this direction. So I'll put that in red. So that's how it should be going, right? And what's happening is once you've got this, now you have, let's just draw it below. So now you have it coming over there, crossing over, coming up to there, and then suddenly getting stretched out in that direction. So this is where the problem actually occurs. Okay, so the issue that you're having now is this huge area that's now curved, and as we know, once you introduce a curve, you increase distance. You are now increasing now the pressure on that neurovascular bundle, and that's where the issue comes about. So and because of the direction of the humerus and the rotation, when you try and get it back in, there's always a possibility that you're going to take the neurovascular bundle into the glenoid cavity. So that's why it becomes a bit difficult with the reduction. Now, because it isn't common, even though if you want to attempt the reduction, no problem. Make sure you've at least seen somebody do it or know how to do it. And if you don't attempt it. Rather let somebody else with more experience do it. But if there is neurovascular impairment, the most important thing is first note your strength of your pulses prior, do the reduction, and then note your pulses afterwards as well as the sensation and power to look at the neurological aspect as well. So those are important things from a medical legal point of view you need to do. So if the patient does have entrapment of the neurovascular bundle, then it ideally needs an immediate CT angio and then vascular management by a vascular team after that. And it is quite a big issue. It's not an easy place to access, and people won't like you if you get trapped in, but it does happen. Even with the best of intentions, the most experienced of providers can still cause a problem. So it's not something you should attempt if you don't know how to do it. Okay. And then this is a superior dislocation. Now, this is extremely rare. I've never seen one, I must be honest. Okay. And it often comes with multiple fractures because it's a force that's coming from the bottom as the arrow indicates. So these are the ones that you don't reduce. Okay. So the problem is that because of the method or the trajectory of the force, there's often rotator cuff injury, quite significant rotator cuff injury, and there's often associated fractures and multiple fractures as well. So as I put here, let the orthopods earn their salary on this one. They really should. Your main thing is to stabilize, give analgesia, prepare the patient so that they can take the patient through to theater and do a proper reduction. Now, in this case as well, there is a bit of neurovascular, possibility of neurovascular injury, but it more has to do with entrapment in this area, and it's not as common. So, don't worry about it as much. Okay. So, hopefully we'll cover the fractures soon. I'll try and do that within the next week or two. And that's just a little joke to finish on. So I hope you guys enjoyed it. And give me any feedback or questions that you have, and we can take it further. All right. Keep well. Bye.